The aim of this session is to try and see if we can achieve alignment at a high level on what improvements are needed when it comes to medicine's use in pregnancy and breastfeeding. And of course, we will focus on what's in the realm of regulators, but no doubt other issues will come up as well. We will hear first a presentation of the EMA strategy on inclusion of pregnant and breastfeeding women, presented by Corinne de Vries, who has already been introduced. And then we will hear two other perspectives, and I will introduce both of them now, before I start giving the floor to the speakers. First, we will hear on behalf of women and patients who use medicines. From the European Institute for Women's Health, we have the pleasure of having with us Hildrun Sandset. Hildrun, of course, is known to many of us as a long-standing board member and president of the European Institute of Women's Health and a member of the EMA Patient and Consumer Working Party. She has contributed to the EIWH policy strategy and communication to make gender equity in public health, biomedical research, treatment, care, and social policies a priority for EU action. And she's been a member of the PCWP for many years, where she tirelessly advocates for the interests of pregnant and lactating women and women in general when it comes to safe use of medicines. After Hildrun's presentation, we will hear from Dr. Paul Ryan on behalf of the Irish College of General Practitioners and the European Union of General Practitioners. Dr. Ryan works as a GP in Cork City in Ireland. He's also a qualified pharmacist and has lectured in the School of Pharmacy, UCC, for the last 13 years. He has founded several online services offering consultation templates in Ireland and the UK, which have collected over 250 evidence-based consultation templates seen in everyday GP practice. It's called gpconsult.ie and also .co.uk if you're interested. And he's also founded prescriptionrevision.ie, which runs which runs live and online tutorials on evidence-based prescribing in GP practice. And before we start, I would just like to say that unfortunately, to make sure we keep on time, we will not be able to take questions from the audience after the presentations, but we will proceed rather directly into a panel discussion. So if there are questions for clarification, I would ask you kindly to put those in the chat, and if our speakers can answer them during the panel discussion, they will do so. I would now then first like to give the floor to Corinne de Vries to present the EMA strategy. Corinne, the floor is yours.
Thank you, Kajsa. As has been alluded to by the previous speakers, at EMA we've been drafting a strategy to help improve the current situation when it comes to information on medicine use in pregnancy and breastfeeding. It is only a draft at present because at the moment and today we are really trying to capture feedback on our current thinking from you as our audience, as our stakeholders, to see whether we are on the right track, whether to explain our thinking, and to really capture from you what you believe we should be doing more of, better, and so on. For that, we also have to explain what we can't do. So it is a bit of everything. I will literally only be introducing this at high level because throughout the day we will be hearing from other speakers regarding the experiences in this area, expectations, what can other stakeholders do where regulators cannot contribute more, and so on. So this is a scene-setting exercise and an outlining of our thinking. So for that, let me then start by talking to you about why is it so difficult to treat pregnant and breastfeeding women. And perhaps you think that this is all obvious, but still I think for setting the scene it is useful. So first of all, if you look at particular molecules and particular structure-activity relationships, we have learned a lot about pharmacological class effects and receptor binding and what the impact is from receptor binding on medicine, activity, and so on, generally. When it comes to pregnancy and breastfeeding, we know a lot less. What we tend to use is animal studies first in the preclinical stages, and there we have globally agreed guidance, the ICH-S5, that stipulates that for reproductive toxicity studies, we need to study one rodent, one non-rodent, and then there is a specification of which rodents are preferred, because those are the ones that we have the most experience with, and so on. But actually, it's poorly predictive. There is some predictivity, but it's not optimal. Then, once we're happy with the non-clinical studies that that there is promise that the product works and is not hugely toxic in the general population, they are the development proceeds to clinical studies, and the aim of those clinical studies is really to demonstrate efficacy. So there are studies of safety, but the main aim is to demonstrate, does the product work? What is the optimal dosage in the general population or in the disease population? And there is no focus on pregnant women for a host of reasons, including the numbers, including really the aim of these clinical trials, which are demonstrating efficacy, and whether the benefit outweighs the risk in the general population. And then, of course, after the clinical trials, after marketing authorization, then the products get used in a much more heterogeneous population, and that includes children, older people who were not necessarily represented in the clinical trials, and pregnant women and breastfeeding women, and it's a much wider range of patient categories. So why do we not really look at safety in this population, in the population of pregnant and breastfeeding women? Well, there are the ethical aspects, but we also don't have the numbers to evaluate safety. So if you think that generally the number of births per women, so we're talking about a high impact population, because globally per year we have 130 million births, of which 5 million are in Europe. And of those pregnancies, about 90% of women take some form of medication in pregnancy. Now, that is a large percentage, and that is because it includes laxatives, antacids, vitamin preparations, folic acid, and so on. But even if you look at more stringent definitions of medicines, or if you really think about medicines being used for treating this medical disorders, 25% of these women have some form of a chronic disease. Some women have infections. Some of the medicines are being used for complications of pregnancy. And then, of course, there is a situation where a woman is using a medicine for a disease that should be treated, generally speaking, with a medicine, preferably. But perhaps not when you're pregnant, or perhaps if you're pregnant, you would choose a different product. But not all pregnancies are planned. So it can then happen that there is a medicine exposure that happens in an unplanned pregnancy, and then the questions arise, is there any unintended impact on the child? And then similarly in breastfeeding, you've got the same distribution or similar distribution of disorders for which medicines are required. And of course, postnatal depression is quite common. So then there is the question about treating the depression and whether or not breastfeeding is then appropriate still. So you'd think, well, we want to study the safety of these medicines in these populations. Well, why don't we do that in the pre-authorization phase? And the reality is that most births are healthy live births, and congenital malformations in the overall population are not that common. They're between 2 and 3% visible at birth, and if you carry on studying over someone's lifetime, it can go up to 6%, but that's overall. Whereas medicines, if they have an impact on the child, they tend to increase the risk of a specific birth defect or the risk depends on the timing of the exposure and what the organ formation or the functional development of the child is at that stage in the pregnancy. So you cannot simply look at all birth defects, but you need to usually look at specific ones. And the numbers just do not exist to do that in a clinical trial, let alone the question how ethical that would be to do it. So what we do instead is we evaluate the safety once the population really is out there, the medicine really is out there on the market. And then we try to have measures in place to make sure that the medicines are used in such a way as to optimize the benefits of the product and minimize the risk. So that if you know it's not, it shouldn't be used in pregnancy, you try to limit the use in pregnancy. We try to provide information on the label of the product about what we know about the safety of the product. But basically what we as regulators can do is we can ask companies to give the benefit risk assessment for their products. We cannot ask, we don't have the legal basis to ask companies to give the relative benefit risk. So how harmful is your product compared with not treating the disorder and the harm of the disease, for example, that is being treated. Or if your product is treating a certain disorder, epilepsy or diabetes or asthma, how does the safety in pregnancy compare with your competitor's product? So as regulators, we can only ask for product-specific benefit risk and not the relative benefit risk to no treatment, other treatments, non-medical treatments, and so on. So our stakeholders often ask us to do more, but our legal basis doesn't really give us that remit. Then also there is the working principles that we have. We need to have the precautionary principle, and we also need to be risk proportionate. So how stringent do we want to be with our labeling and our guidelines and so on? So, of course, there are things that we can do. So we have existing methods of periodic safety update reports that we receive from pharmaceutical companies and we assess. We do our analysis of spontaneous reporting. There are studies in breastfeeding, but perhaps we should be looking at those and saying, okay, can we do more here? Can we do better? Can we analyze better? Can we ask for more data? And how do we translate this into the most appropriate risk minimization measures? And then there are things that are happening out there or that we can ask others to do. That is not our remit, but we can certainly support or be involved with our stakeholders on, for example, considering innovative non-clinical methods, learning from epigenetics, and I've got a photograph here of the impact throughout generations of exposure in utero. So this is in the Dutch famine in the Second World War. Children were born underweight, small for gestational age, and so on, and even the third generation after them is still has a higher risk of cardiovascular disorders, for example. We can look at different study designs. We're working together with the public-private partnership Conception, where they're working on human breast milk studies in biobank, as well as a sustainable infrastructure for evidence generation. And I won't go into too much because you will be hearing more throughout the day. So what we are looking at the moment at EMA and together with our stakeholders is what can we do at the preclinical stage? So how can we use better pharmacokinetic studies, PBPK studies? Can we support the development and the regulatory acceptance of innovative methods in the preclinical space? Should we be thinking differently in the clinical trials about benefit risk in the antenatal phase, not including pregnant women in clinical trials where there is a hazard to the woman and no benefit? But there are exceptions, for example, where you think, well, if there is no treatment available and a woman is at risk of dying, but there is an experimental treatment that might work, should we really be as black and white as saying, well, no pregnant women ever in a clinical trial? But mostly at the moment our focus has been on post-authorization. So how can we use better existing methods and how can we develop new methods and infrastructure to evaluate the use that is happening, and how can we help communicate the uncertainty that is surrounding the risks and the benefits. And that is actually something that also requires special communication skills in our view. And again, that is not necessarily regulatory remit, but we can perhaps support it better than we are currently doing. So that outlines our current thinking. And with that, I thank you for your attention and encourage you to really do questions in the Slido page, which we will be able to take up in the plenary discussion later. Thank you.
Thank you very much, Corinne. And I think we will turn directly into the next presentation, which is from Hildrun Sunset at the European Institute of Women's Health. Hildrun will give us the perspective of the patient. The floor is yours, Hildrun. Please go ahead.
So thank you to Corinne for setting the scene and highlighting the challenges that the regulator has. Here I'm obviously speaking for women's health and from the women's health perspective, and we experience very much the information gap on safe use of medicines in pregnancy and breastfeeding. Could you like do the next slide, please? I don't know how to. Yeah, here. No, that's one. This slide tells you about the relationship, the very useful and a valuable relationship that women, when they're pregnant or planning pregnancy, have with their health care professionals. But in reality, often healthcare professionals don't have all the information either. So that is why it's very, very important to have the information available both for women and their healthcare professionals. Next slide, please. Can I have? Yeah. So just to give you a little background, I think we all are familiar of the thalidomide tragedy, which resulted in pregnant women's exclusion from clinical trials and research. However, we are now moving into the 21st century and new tools are available. So I think there is now a need to look at for regulatory strategy to protect pregnant and lactating women. And the EMA Regulatory Science Strategy of 2025, of which we will hear more, I'm sure, will certainly be an opportunity to address this unacceptable societal neglect. And one of the issues we think that is most useful and we could do right now is to learn through pharmacovigilance reporting, to have a better pharmacovigilance system set up in this area. Next slide, please. So the reality, Corinne mentioned it, I probably have different figures because it varies wherever you look. The estimate I've come across is that out of 5 million women delivering babies each year, there are about 130,000 birth defects in the EU 27. Birth defects are estimated to cause 11% of neonatal deaths. Next slide, please. So 7 out of 10 pregnant women use prescription medicines. Pregnant women with asthma, depression, diabetes, epilepsy, HIV/AIDS, hypertension, to name just a few, need to take medicines during pregnancy. However, the robust evidence how a medicine works in pregnant women and its appropriate dosage is lacking. Instead, there is often off-label use and therefore no learning. Next slide, please. The European Institute of Women's Health is engaged in an IMI project conception. This is a public-private partnership that looks at this area, and to start with, our One Work Package 5 did a survey, and they found a total of 1,910 women from 74 countries completed the questionnaire. Approximately 85% of the women reported need for information about medications during pregnancy and lactation. What we found out from this survey is that medical doctors and internet were the most used information sources. Next slide, please. Almost half of the women reported their medical doctor as their preferred information source. And that brings me back to my picture in the introduction. In the introduction, a doctor talking with the patient, with the female patient. Over half of the women had experienced discrepancy between different medication information sources. This is naturally very confusing. 405 women reported having had difficulties understanding information given. Most common reason, information was not precise enough. Next slide, please. The healthcare professionals were also surveyed, and 656 healthcare professionals completed the survey. More than 60% of healthcare professionals reported being asked information use on a daily, weekly basis. Pharmacists, specialist physicians, and GPs were most frequently asked. 60% of healthcare professionals were native English speakers. Next slide, please. Frequently used sources were online database, website, medical specialists, desk reference, or textbooks. Next slide. So now, just to make sure that we understand that this problem is not, this challenge, I should say, is not restricted to Europe, it's worldwide. NIH, the National Institute of Health in the United States, set up a group called BRACLAC, protecting, and I like their slogan very much, protecting women through research instead of from research. BRACLAC has done some background studies, and they have been tasked by the U.S. Secretary of Health and Human Services to identify the knowledge gaps and research on safe and effective therapies for pregnant and lactating women. And I think it's important that if we move ahead, we move ahead also across countries and continents, because women nowadays use the internet, and it would be good to have the same sort of information available from both agencies in the US and in Europe. Next slide, please. So, the European Institute, it was already mentioned by Kaiser, we've been calling for action in this field for many, many years to address the knowledge gap. And one of the ways we thought one could take first steps, as improving post-marketing data collection and work with a learning health system. So that means, it's a big word, I know, but it would mean collect real-world data from various different sources. Another opportunity would be to have common rules for pregnancy exposure registries or have disease registries. And then, of course, all this needs funding. So we would really want to see some more investment and support and reward for research in this neglected field. Next slide, please. So the way forward, as we see it, and we are very happy to have seen that the EMA Regulatory Science Strategy 2025 will be addressing this issue, and we think we can also harness the digital tools that are available nowadays, and ideally we would like to see setting up a regulatory updated information system or knowledge bank, but this would clearly need a commitment and funding. So this is my last slide. Thank you very much, and I look forward to the discussion. Thank you.
Thank you, Hildren, for outlining very well the issues faced by patients. There were a lot of ideas in your presentation as well. Now we will hear from the side of the clinical care side, so from the physician side, and I'm pleased to welcome Dr. Paul Ryan. And I see your slides are already up, so the floor is yours.
Hello, my name is Paul Ryan, and I'm delighted to be here today to talk to you. Next slide. So I work both as a GP and a pharmacist here in Ireland, and I'm going to just discuss my own difficulties when dealing with my pregnant patients who are on medication. So the main issue for me is that drugs are generally contraindicated in pregnancy. So especially during the first trimester, where organogenesis occurs. So, and very few drugs are considered safe. And if you look at the summary of product characteristics on the medicines, the advice tends to be very conservative on the use of medicines in pregnancy. But if we stop these medications, it can lead to worse outcomes for both mum and baby. So, such as my patients who have asthma, diabetes, if they have bipolar affective disorder, schizophrenia, major depression, or epilepsy. So, next slide, please. So, what I do discuss with my patients, obviously in the ideal situation, I give good pre-pregnancy advice: folic acid, cut down on alcohol, cigarettes, exercise, diet. But depending on the study, up to 50% of pregnancies are unplanned. So there's actually little data on most medications during pregnancy or breastfeeding. So very few drugs are considered safe, and I explain to my patients that it's because it's unethical to expose these patients to show safety of a medication. So and I hope I can see in the chat function as the volume low, so I'll speak loudly. So the background risk, irrespective of exposure to either a drug or a chemical, is miscarriage or spontaneous loss, which is 10 to 20%, and a congenital abnormality, which is about 2 to 3%. Next slide. So the two main situations in our own practice is you're either starting a medication in pregnancy, or if the lady is already on medication, and then your option is either to continue the medication, to stop the medication, or else change the medication to an alternative. The main issue with this is that a lot of these medications I cannot abruptly stop without considering the risk of relapse or illness. So I do discuss with my local pharmacist as well, or a secondary care colleague. So next slide, please. So thankfully, a lot of the situations where I prescribe medicines to pregnant ladies are with antacids such as sodium alginate, for reflux, iron supplements for anemia, certain laxatives such as ispagula, topical antifungals, which is like topical clotrimazole, folic acid, obviously to help prevent neural tube defects, or asymptomatic bacteriuria or lower urinary tract infections, where nitrofurantoin in Ireland would be the drug of choice. So next slide. So the active management of asthma during pregnancy outweighs any potential risks associated with the use of asthma medicines. And a lot of times, I currently have a number of pregnant patients who have asthma, and this, I go through this with the patients. Obviously, when people are in pain, paracetamol is safe, and topical corticosteroids for eczema are also safe. Okay, next slide. So I'm going to talk about our own practice currently. We have 3 pregnant patients currently with asthma and 1 lady with epilepsy. And I'm going to focus on the lady with epilepsy because this to me brings uncertainty. There's uncertainty when you're dealing with neuropathic pain, antidepressants, pregnant ladies with migraine, biological agents. And the reality of this uncertainty is that I am making clinical decisions based on a limited amount of data. Okay, so next slide. So how I try best to handle uncertainty. So this is, I feel it's key. The patient-doctor or the patient-pharmacist relationship is key, and it's trust, and it's being open with the patient and explaining our own limitations, whereas most of the time I'm very confident in the safety of a drug, but people are, some of my pregnant ladies, if I'm prescribing a medicine, I have to share that uncertainty and talk them through it. I discuss the risk-benefit ratio and what is the risk of stopping this medication, and also emphasize that it's a shared care with hospital consultants and pharmacists, that it's a team effort, okay, with the patient at the center of this. The data that there are a number of different websites that I find helpful, and then I translate. I think it's translating this information to the patient. So I would use drawings, I would use graphs. It's time to give with the pregnant patient as well, just to talk to her about the risks and about the benefits and the risks, like with any treatment, the benefits and risks. So the next slide, please. So I'm going to talk about a patient of mine who's on Keppra, levetiracetam. She's a lovely lady, 24-year-old lady, and she has been on Keppra for the last 6 or 7 years. She's been seizure-free for 5 years. She's a background history of complex partial seizures. Now, she had an unplanned pregnancy, and obviously that was a lot for her to deal with at the time. So she had not been taking folic acid, but we obviously the first thing, we got her on the folic acid, and the next question then is to continue the levetiracetam or not. So obviously it was shared care with neurology, obstetrics, the local pharmacist, and another issue was that she was very nauseated at the very start of pregnancy, and so she wants to know if she vomited, within a certain amount of time, when does she need to take another dose of levetiracetam. So just the practicalities of it. So and now next slide, please. So we had to take the levetiracetam trough levels at least each semester because the levels dropped due to glucuronidation, and we want to make sure that she did not have a seizure. The levels obviously were taken on ice, and if she was to have a seizure, to explain about the buccal-midazolam, and that's another medication then to talk about the risks and that. So we obviously got her registered on the Irish Epilepsy Pregnancy Register, and thankfully she had a healthy baby boy 2 months ago, and I did the 6-week check just a number of weeks ago, and mom is happy and baby is beautiful. So thankfully that was my good news story. But there was initially it was a difficult consultation, and it was a difficult situation, and there was for me, I actually got closer to the patient. I was sharing my uncertainty with her as well. So, next slide. So considerations, and obviously we have to consider breastfeeding. Okay, so if the medication is initiated in pregnancy, consider the safety in breastfeeding. So because the majority of drugs are unlicensed for use during lactation, and it's great to see that there's a lot of people interested in breastfeeding on this conference as well, and I'm only delighted to talk or to answer questions after as well. Data may be available on the amount which gets into breast milk. And premature, you have to look at the babies as well. So premature babies are obviously particularly susceptible to drugs and may exhibit higher than expected drug levels. And then you also have to look, number one, at the babies, and number two, at the breast milk. What is the volume of the breast milk taken daily? So a 4-week-old fully breastfed baby versus a 10-month-old feeding once daily. So that has to be taken into consideration. Next slide there. So what is needed? What I would love, and this is why I'm delighted to be talking at this conference, and I'm so delighted to hear from Corrine and Hildrum as well. We need more formal evaluation of women who have taken medications during their pregnancy. We need prospective data with good methodology in order to give good quality data. And this will then allow us, inform us as doctors and pharmacists to help our pregnant or breastfeeding patients, so that when hopefully we're in a situation in 5 years' time, I'll be more confident in showing the safety of a medicine for my patient. And next slide, please. So these are the websites that I use. That I find helpful. And I'm looking forward to answering any questions at all at the end. So thank you very much for having me, and I hope you heard me, and I hope I didn't speak too fast.